Dear friends, as you all are aware of the fact that the invasive arterial pressure monitoring using arterial catheterization is one of the commonly performed bedside procedures in the ICU during shock when non-invasive blood pressure monitoring becomes unreliable. What are the various techniques to insert arterial cannula? Basically, there are two approaches for arterial cannulation: the blind approach and ultrasound-guided approach. In blind approach, the radial artery is palpated between the distal radius and the flexor carpi radialis tendon. Ultrasound has made our lives easy. This can be performed in the centers where an ultrasonography machine or ultrasound machine is available and expertise in ultrasound guided arterial line insertion is available. The success rate of radial arterial cannulation has been shown to be higher with the use of ultrasound guided cannulation. This technique is especially suitable for critically ill patients with feeble pulse, obese and edematous cannulation site. A sterile probe cover or a sterile glove may be used to cover the ultrasound probe as a barrier to prevent cross-contamination. Full aseptic precautions are taken during the cannulation. Now, there are two approaches which are commonly used to visualize the artery using ultrasound and its catheterization also: in plane approach and out of plane approach. Both approaches have their own disadvantages and advantages. Now, in plane approach can be described where the radial artery is scanned in plane. In plane means that the long axis of the probe is kept in line with the long axis of the artery so that it scans the longitudinal section of the artery. The advantage of this approach is the real-time visualization of the tip of the needle entering inside the lumen in real time. However, it requires good expertise to hold and stabilize the probe during the procedure. Out of plane approach is also very popular nowadays, and this technique is easier to learn and master, and it is also very quick technique. In this method, the long axis of the probe is perpendicular to the long axis of the artery in such a way that a transverse section of the artery is visualized on the ultrasound screen. Now, the disadvantage of this technique is that the loss of real-time entry of the needle. If one is not careful about the moving the probe in the direction of the needle entry, that may result the posterior wall puncture and posterior wall hemorrhage of the artery. That is why the target sign is always seen. That is the end point in this technique, and when one can see the bright spot needle tip image inside the lumen of artery. The success of either approach is heralded by free and pulsatile backflow of the blood in the needle hub. In the outplane approach, the dynamic needle tip positioning is very useful for the traditional catheter over needle type of arterial cannulation. For the D and TP technique, the probe is placed to view the out of plane radial artery view, and its position is adjusted to place the arterial shadow or arterial image in the center of the ultrasound screen. So you have to adjust the probe like that, and then the needle is inserted at a point at which the middle mark of the probe or the black mark of the probe is contacting the skin and advance through the skin at an angle of approximately 30 degrees until the tip is seen inside the center of the arterial image. Then the probe is moved along the long axis of the target artery away from the insertion point until the tip of the needle just disappears from the screen. Then we advance the needle again and catheter until the tip is again seen. Okay, and these 3 steps are repeated 3 to 4 times to ensure that the catheter is 3 to 4 millimeter inside the arterial lumen and not just a needle tip. Okay, so that's all for today. Thank you so much for your attention.